Let us discuss the GIT, gastrointestinal tract, or the digestive system. It's a very straightforward system. So at the entrance level, if the MCQs are asked, they are not very deeply conceptual type of MCQs, because the system itself is a very straightforward, simple system with a lot of factual information. We will be discussing this system under 3 sections. First we will take the introduction, then the motility of the digestive tract and the secretion of the digestive tract. Let's start with the introduction. If you take a typical transverse section across the GI wall, there are 4 layers in the transverse section. The mucosa, the mucosal layer, then the submucosa, then muscularis mucosae, the muscle layer, the smooth muscle lining the digestive tract, the muscularis mucosae, and then serosa, the serous layer or the serosa. And outside that, there would be peritoneum covering the wall of the digestive tract. These are the 4 layers in a typical transverse section in the digestive tract. Let's see the first aspect, and that is innervation in the digestive tract. There is enteric nervous system, the ENS. Some aspects of ENS may be known or should be known, particularly that enteric nervous system is considered to be a branch of ANS. ENS is a branch of ANS. Second point, ENS is such an extensive network of neurons, this enteric nervous system, such an extensive network that it is sometimes called as mini brain or peripheral brain. Just as there is peripheral heart, the calf muscle or gastrocnemius and soleus muscle, there is peripheral brain or mini brain, the enteric nervous system, the innervation in the digestive tract. This ENS has 2 plexuses, the nerve plexuses of the ENS. The submucous plexus, the submucus is the Meissner's plexus. It is the same Meissner, the George Meissner who discovered this plexus, who also discovered that Meissner's corpuscle in the skin, the touch receptor, also pseudo-Meissnerian corpuscle named after him, Meissner's plexus. And then that's in the submucous layer. The other one is the myenteric plexus in the muscle layer, which is called as Orbach's plexus. So 2 extensive networks or plexuses of the nerves. Meissner's plexus is mainly concerned with the sensory function from the digestive tract, and Orbach's plexus, since it is present in the muscle layer, this is mainly concerned with the motor function. The motility, contractions and secretomotor function is mainly controlled by the Orbach's plexus. So that's a rough division of work between these 2 plexuses. Talking about this ENS, what are the various neurotransmitters in the ENS? The neurotransmitters in the ENS, commonest excitatory transmitters in the ENS are acetylcholine and substance P. These are the commonest excitatory transmitters in the enteric nervous system. Commonest inhibitory transmitters are VIP and NO, vasoactive intestinal polypeptide, VIP and NO nitric oxide. VIP inhibits the motility. In that sense, it is the inhibitory neurotransmitter, but it stimulates some of the secretions. So, but it is by and large the commonest inhibitory transmitter in the digestive tract, in the ENS. Next point, electrical activity in the gut. Electrical activity in the gut is typically, it appears like this. There is a slow wave reaching the threshold, and at the top of the slow wave there are spikes. The spike, a single or multiple spikes. So a slow wave and then the spike at the top of slow wave. That's the electrical activity in the digestive tract, a typical electrical activity in the smooth muscle lining the GI tract. Now this electrical activity occurs with a certain pace, and that pace differs in each part of the digestive tract. So there is a pacemaker cell which determines this pace of the electrical activity. The frequency of this electrical activity is different in different parts. So which cell is called as the pacemaker that will determine this pace or electrical activity? The pacemaker cell in the gut is called as interstitial cell of Cajal. Interstitial cell of Cajal. That's the cell called as the pacemaker cell. It is like this. Here is a smooth muscle lining the in the wall of the digestive tract, and here is a neuron of the enteric nervous system. So interstitial cell of Cajal is between these two cells. It synapses with the smooth muscle and it synapses with the neuron of the enteric nervous system, and this cell is said to be the pacemaker in the digestive tract. Now this electrical activity occurs with a certain frequency, and that frequency also differs in different parts. So it's called as BER, the basal electrical rhythm in the digestive tract. The basal electrical rhythm, the BER, and there was this question, BER, its highest frequency is seen in which of the following parts? And the options were stomach, duodenum, ileum, stomach, duodenum, jejunum, ileum. The answer is, among the given options, the answer is duodenum. Let us see the frequency of BER. Stomach, this electrical activity occurs 3 to 4 times per minute. The BER, basal electrical rhythm, is said to be the electrical activity occurring in with what frequency, and that's 3 to 4 times per minute. Second, small intestine, duodenum, jejunum and ileum. The activity, the BER frequency will go on decreasing. 12 per minute, 9 per minute, 7 per minute. And this decrease of BER from duodenum to ileum is responsible for the law of the gut, law of the gut, law of the intestines. The law of the gut is oral to anal direction of peristalsis. Oral to anal direction of peristalsis. That's the law of the gut. Now then, there is only one exception to this law of the gut. So there is an MCQ. Antiperistalsis is naturally seen in which part of the gut? The options are stomach, duodenum, stomach, ileum, colon, or nowhere in the intestine. Look, we are talking of antiperistalsis naturally occurring. We are not talking about vomiting, which is also an antiperistalsis. We are talking antiperistalsis. Does it occur naturally anywhere? Because we have already said that oral to anal direction is the natural direction of peristalsis. Yes, the answer is colon. Colon is where antiperistalsis is seen naturally. Let us try to understand why and how. The ascending colon, then the transverse colon, descending colon, and then sigmoid colon. Now, as we have seen in the small intestine, the frequency of BAR went decreasing, 12.97 per minute, and therefore there was oral to anal direction of peristalsis. That was the law of the gut. But over here, the frequency is in the sigmoid, it would be 6 to 9 per minute, and in the ascending colon it is 2 to 6 per minute. The point that I am trying to make is that this is a reversed gradient of BER. You can see that BER is frequency is less over here and more in the later part. This is responsible for the antiperistalsis. So remember, antiperistalsis is naturally seen in only one part of the digestive tract, and that is from hepatic flexure of the colon to the cecum. In this direction is the only place where antiperistalsis is naturally seen. Let's try to understand why. I mean, what is the significance that antiperistalsis is naturally seen here? Well, the significance lies in this. You see, ascending colon and half of the transverse colon, this part is called as absorptive colon, and then the remaining part of the colon, transverse colon, descending colon, this is called as storage colon. So what you can see here is that this is the last time that absorption of water and minerals will occur from the colon, and then the feces will be formed, and then those feces will be stored in the remaining part of the colon. And because this is the last time to absorb water, therefore what happens is there is one peristalsis like this, forward direction, and there is one antiperistalsis from hepatic flexure of the colon to the cecum, and again peristalsis. In this manner, there would be a back and forth movement so that all the water can be absorbed, and finally fecal matter will be formed, feces will be formed finally. But this is the physiology of the colon. Now, there was one MCQ which is related to this. It tricks you actually. The MCQ is, greatest water absorption occurs from which part of the digestive tract? And the options are duodenum, jejunum, ileum, colon. Our natural tendency is to think of the colon, because we have already said that colon absorbs all the water coming into it and finally forms the feces. So it is naturally felt that colon is where maximum water absorption occurs. But no, that's not the case. The answer is jejunum. Jejunum absorbs some 6.6 liters per day, and colon absorbs 1.5 liters per day. Remember this, we will talk about it later once again in the digestion and absorption of the nutrients. Right, so that's the BER, the basal electrical rhythm in the digestive tract with its various frequencies and peristalsis and antiperistalsis as well. Let's see one more aspect, reflexes in the digestive tract. So far as the reflexes are concerned, there are three types of reflexes. But before that, let me ask you a simple MCQ. Upon rising up from the bed in the morning, defecation is initiated by which reflex? And actually I gave you a hint by showing hand gesture. Upon rising up from the bed in the morning. Well, the options are gastroileal reflex, gastrocolic reflex, orthocolic reflex, and mass peristalsis. The answer was actually orthocolic reflex. Upon rising up straight from the bed in the morning, orthocolic reflex initiates the defecation process. Okay, let's see the reflex types. First type of reflex is called as local reflexes. They are entirely confined to the digestive wall. Entirely confined to the ENS. Confined to the ENS. That's a local reflex. Example, peristaltic reflex is a local reflex, entirely confined to the enteric nervous system and to the digestive wall. Second type of reflex is the short loop reflexes. That is from ENS to spinal cord and back. It would be a short loop reflex. Orthocolic reflex would fit into this category because when the spinal cord position is changed from lying down to standing, it would initiate what is called as orthocolic reflex. Upon going into the straight upright position, the contraction, the reflexes will be initiated. That's defecation process will be initiated. And the third one is long loop and ultra long loop reflexes. So long loop reflexes would include enteric nervous system, spinal cord, and even the higher centers, the cortical centers even. This includes, the example is true defecation reflex. Defecation process or true defecation reflex involves higher centers as well. So these are the types of reflexes associated with the digestive tract. Let us now talk about the first aspect, that is motility in the digestive tract. Motility in the digestive tract. We will first discuss how the food moves along the digestive tract from oral to the stomach, then small intestine, colon, etc. Then we will also discuss the secretory activity in the digestive tract. So, motility, let us start with deglutition. Some important aspects of deglutition. Swallowing. Swallowing has three phases. There are three phases of swallowing. Entire process of swallowing occurs in 10 to 12 seconds, and it has got three phases: oral phase, pharyngeal phase, and esophageal phase. Only the oral phase is voluntary. The next two phases are involuntary. They occur as a reflex, or they are involuntary processes. So, involuntary phase or the reflex phases, they are controlled by the swallowing center in the medulla. Let's first look at the first phase, oral phase. The tongue is pressed upward and backward so that the bolus of food is pushed into the posterior pharynx, and from then on the involuntary phase will start. So the first phase was voluntary. Now the pharyngeal phase, occurring as a reflex, and this reflex is coordinated at the swallowing center. So what happens is, this reflex is started when food particles, they touch the pharyngeal wall. Particularly sensitive areas are tonsillar pillars. When some food particle touches there, there would be reflexes that are initiated, and then swallowing center in the medulla, and then this swallowing center will temporarily call deglutition apnea. That swallowing center will inhibit the nearby respiratory center of the medulla, so that respiration will be temporarily inhibited, and then it sends the signals back so that there are coordinated contractions seen in the pharynx and esophagus. Ninth and 10th nerves are involved in this act. Now, what are the events that occur in the pharyngeal stage of swallowing? A bolus of food is pressed backward. Then the pharyngeal stage has started. Upper esophageal sphincter relaxes. Now, here is the a diagrammatic representation. There is relaxation of the upper esophageal sphincter. Then following things will happen. One is the two passages will be closed first. The soft palate moves upward so that the posterior nares are closed, so that the bolus of food does not regurgitate from the nasal cavity. Second point, epiglottis falls over the respiratory passage. So respiratory passage is closed, the food particles do not enter the respiratory passage. So first thing is these two passages are closed where food is not supposed to go. Next, palatopharyngeal folds approximate near the midline. The palatopharyngeal folds will come near the midline and they leave just a slit through which the bolus of food has to go. So remember, if the bolus of food is large, it cannot be swallowed because it has to negotiate this slit created by the palatopharyngeal folds. Then the opening of the esophagus is widened and a wave of peristalsis will be sent down the esophagus. These are some of the events that occur in the pharyngeal phase. And then esophageal phase, the lower esophageal sphincter, also called as gastroesophageal sphincter, is a physiological sphincter. Among all the sphincters, there are 6 in all in the digestive tract, 6 sphincters, out of which this sphincter is called as physiological sphincter, which means what? There is no anatomical entity there acting as a sphincter. That area acts like a high pressure sphincter area. Therefore, it's a functional sphincter and no anatomical entity. So, esophageal phase, well, in the pharyngeal phase, a wave of peristalsis went down and then the esophageal phase starts. In the esophageal phase, you see a primary peristalsis, but before that, already there was relaxation of the lower esophageal sphincter. So, primary peristalsis means the wave that started in the pharyngeal stage, in the pharynx, it comes down, and another wave called as secondary peristalsis. If some particle could not be cleared, then one more wave of peristalsis will come down the esophagus, so that finally all the food will enter from esophagus into the stomach. These are the stages of swallowing. Next, let's see the motor functions of the stomach. Once the food has gone into the stomach, let's try to understand the motor functions of the stomach. There are 3 important motor functions by the stomach. Let me tell you an interesting fact. Stomach is not essential to life. There are so many functions, motility, storage, etc., secretions. Stomach is not essential to life except for one function, and that one function is secretion of intrinsic factor of Castle for absorption of B12. That's the only function that's essential to life for the nuclear maturation. Okay, coming to the motor functions of the stomach. There are 3 motor functions of the stomach. Storage, mixing, and slow emptying. These are the 3 functions motor functions performed by the stomach. Storage. Well, the important thing related to the storage is receptive relaxation of the stomach wall. Receptive relaxation of the stomach wall. When the food comes into the stomach wall relaxes and accommodates the food so that 1 to 1.5 liters can be accommodated without allowing the intragastric pressure to rise much. That's the importance of receptive relaxation and the storage capacity of the stomach. There was one MCQ also that should be discussed. Pacemaker complex of the stomach is located in which part of the stomach? And the options were fundus, mid portion of the body, distal portion, and pylorus. Well, we are tempted to answer as fundus because it is at the highest position, but no, that's not the answer. The answer is mid portion of the body of the stomach. Pacemaker complex of the stomach is located in the mid portion of the body. Fundus does not need a pacemaker activity. Fundus is just there to accommodate the gases and then cause belching and retching. So pacemaker activity required from the mid portion of the body of stomach. That was the first function, storage function. Second motor function is slow emptying. I beg your pardon. Second function is mixing. And the most important event in the mixing process and formation of chyme is called as retropulsion. Formation of chyme, most important event is said to be the retropulsion. So what happens is some part of the pylorus, this wall, will contract so that already the foods have been mixed with the gastric juices and a semi-solid paste called as chyme has been formed. So now with the contraction of the pyloric wall, some chyme will escape through the sphincter, but the remaining will just go back. This is called as retropulsion. Propulsion, retropulsion. Then this which has gone back will come forth. Pyloric wall contracts so that some of it escapes further, but the remaining just goes back again. The retropulsion. Therefore, this back and forth movement causes a thorough mixing of the foods with the gastric juice and forms the chyme. Most important event, therefore, is retropulsion in the stomach. Third function is slow emptying. There is slow emptying of the chyme into the duodenum. The normal gastric emptying time is 4 to 6 hours. By 4 to 6 hours, all the food will have been emptied into the duodenum. Well, it is longest for the fatty foods. It's 8 hours. Fats are emptied in the end. So this you might have experienced sometimes, that when you eat the fatty foods, you don't feel hungry for a longer duration after that. If there is a sense of fullness for longer duration, because gastric emptying time is longest for the fats. Let us see the factors that influence gastric emptying. Factors influencing the gastric emptying. There is only one weak factor, and that too it's a gastric factor. So weak gastric factor that promotes gastric emptying, hastens gastric emptying, and that is the hormone gastrin. This is the only factor that will hasten the gastric emptying. It will reduce the gastric emptying time. All the other factors are strong factors. They are all duodenal factors. So strong duodenal factors which will retard or inhibit the gastric emptying. 4 important factors which all of them are duodenal factors, and they will retard or inhibit the gastric emptying. So let's look at them one by one. First, acidic chyme entering the duodenum. Now you know that duodenum has to have the action of the pancreatic enzymes, and pancreatic enzymes need an alkaline pH. So if lot of acidic chyme enters the duodenum, then digestion will be difficult by the pancreatic enzymes. So further gastric emptying has to be prevented. So when the acidic chyme enters the duodenum, there will be secretion of secretin from the S cells in the duodenum, and then secretin will go back to the stomach and it will cause constriction of the pyloric sphincter. It will contract the pyloric sphincter, so that further gastric emptying will be prevented. Next, second factor is irritation of the duodenal mucosa. Irritation of the duodenal mucosa. Now, this happens in the case of poisonous substances, harmful substances, irritating substances. If they enter the duodenum and they are likely to be absorbed from the duodenum, that's going to be harmful. So what happens is, when they enter the duodenum and there is irritation of the duodenal mucosa, further gastric emptying will be prevented. There will be initiation of enterogastric reflexes from the duodenal wall to the stomach wall, and further gastric emptying will be prevented, stopped, so that then the contents remain in the stomach itself and they can be vomited out. So therefore, remember, irritating poisonous substances, they are likely to induce vomiting, so that they are expelled out of the body. Third is hypertonic contents reaching the duodenum. Hypertonic contents reaching the duodenum. There is a syndrome called as dumping syndrome. When the persons who have undergone gastrectomy or some partial gastrectomy or surgery on the stomach, then what happens is, the hypertonic contents, they reach straight away into the duodenum. Stomach is not able to normalize their tonicity, and then what happens is, hypertonic contents straight away reaching the duodenum, I'm talking about those people who have undergone surgery, then they will cause water to be pulled from the blood vessels in the wall of intestine, because they are hypertonic contents, and lot of water will be pulled by osmosis, causing a decrease in the blood volume. Suddenly the blood volume will decrease after some time of the food, and then resulting in fainting or something. That's called as dumping syndrome. After eating the food, sudden decrease in the blood volume. Now that is prevented normally by this mechanism, prevention of gastric emptying. So when hypertonic contents reach the duodenum, there are osmoreceptors in the duodenal wall. These osmoreceptors in the duodenal wall, they will initiate the enterogastric reflexes after sensing the hypertonic contents. And from the duodenal wall to the stomach wall, the enterogastric reflexes, they will stop the further gastric emptying. And the fourth factor is fat breakdown products in the duodenum. Fat breakdown products in the duodenum. When fat breakdown products reach the duodenum, then there is release of CCK from the duodenal mucosa, and this CCK, why the further gastric emptying needs to be prevented is because fat digestion and absorption is not as simple. It is complex, and therefore a lot of fat should not come immediately into the duodenum. So when fat breakdown products start coming into the duodenum, CCK will be released by the duodenal cells, and then it will go to the stomach and it will decrease the gastric motility. so that gastric emptying is prevented. This is how after eating fatty foods we feel a sense of fullness and satiety for a long period of time. This is the stomach motility. Next, let us see the motility of the small intestine. Motility of the small intestine can be divided into two parts. In the fed state and in the fasting state. In the fed state, before I tell you about the small intestinal motility, let me tell you an interesting fact about the small intestine. Length of the small intestine in the living is about 2.77 meters. Length of the small intestine in dead is 6 meters. The length is increased after death. The reason is that the living beings have villi and microvilli, the folds of the small intestinal wall, and therefore the length has decreased. After death, they will all be prolonged, straightened up, and the length will increase. Anyways, coming to the small intestinal motility. In the fed state, we have two movements of the small intestine. One is called as peristalsis, and the other one is called as segmentation contractions. Peristalsis is for propulsion of the foodstuffs, and segmentation contractions are for the purpose of mixing. In the fasting state, the motility of the small intestine, first there will be hunger pangs, and then the motility in the fasting state is described as migrating motor complexes. There was an MCQ which was asked in the entrance exams long back. Which of the following is called as the housekeeper of the intestines? Housekeeper of the intestines is, and the options were the bile, the succus entericus, the MMCs, and segmentation contractions. The answer is MMCs, migrating motor complexes. This is the motility of the small intestine in the fasting state. In the post-absorptive state, let's see some important points related to this. One is, this is called as housekeeper of the intestines. Housekeeper of the gut. It means in the post-absorptive phase, clearing the food debris and some digestive juices and some other material which could not be cleared from of the sphincters. Now that will be cleared in this phase. So cleaning up act, and therefore it is called as housekeeper of the intestines. Second point is the migrating motor complexes at one place. You know why it's called migrating motor complex? Is that at one place in the intestine there will be a 90-minute cycle, and then that complex will move to some other part, and that 90-minute cycle will be repeated. So that's why it's called as a migrating motor complex. It's a 90-minute cycle at one place. Now, what are the things happen in this 90 minutes? There are three phases of the migrating motor complexes. Three phases. Phase 1, first 70 minutes. This is called as quiescent phase. Quiescent phase means only slow waves. These slow waves are not followed by the contractile activity. No peristaltic or contractile activity seen. Second, phase 2, it's about next 10 to 15 minutes. Now the irregular contractions will start. Irregular contractions will start. Means some slow waves will be quiescent, means not followed by contractions. Some slow waves will be followed by the contractions. And third phase, the phase 3, is called as the activity front. This is for the last 5 to 10 minutes of the cycle. Is the activity front, means each slow wave will be followed by contraction. There will be a slow wave, then the contraction, slow wave, contraction, contractile ring. Now the contractile ring will start from that point and it will travel over the entire length of the intestine, entire remaining length of the intestine, starting at this point where you are seeing the MMC. Starting from there, and it will travel the entire length. So all the food debris, the digestive juices, some remnants, all those will be cleared like this. Well, that's the difference between a peristaltic wave and a contractile wave of the MMC. Peristaltic wave, it just travels over a few centimeters of the intestines and dies out. This wave, starting from this point, will travel over the entire length. Now, the hormone that strengthens the MMC contractions is motilin. Motilin is the hormone that strengthens the MMC contractions. And the drug that binds to motilin receptors is erythromycin. So erythromycin, although it is a macrolide group of antibiotics, it is the drug that binds with the motilin receptors. It strengthens the MMC contractions, and therefore it can be given as a prokinetic drug. These are the motor functions in the small intestine, motility of the small intestine. Motility in the colon is similar. The similar types of contractions are also seen in the colon, the segmentation contractions and peristalsis. It's very similar to the small intestine. And in addition, colon also shows hostrations, those outpouchings where the matter can be temporarily stored. So that's about some aspects of motility in the digestive tract. Now let's see the third section, and that is secretions in the digestive tract, secretory activity of the digestive tract. We will first see the peptides, regulatory peptides associated with the digestive tract. And then we will actually see the secretions like saliva, gastric juice, pancreatic juice, bile, and so on. So first, let us see the regulatory peptide secretions in the digestive tract. So we will see the cell and its secretion, and then its functions. So let us start with the stomach. Stomach has the following cells. ECL cell in the stomach. ECL cell. Enterochromaffin-like cell. This cell secretes histamine. Histamine, what is the function of histamine? Histamine acts via H2 receptor on the parietal cell. It's a neighboring cell. So it's a paracrine effect. Histamine acting on the neighboring cell, it's a paracrine effect. And what will it achieve? It will increase the gastric acid secretion, and it plays a pivotal role in the gastric acid secretion by other stimuli. So let's just say potentiating effect on the other two stimuli, that is vagus and acetylcholine, and the third is gastrin. You see, there are three important stimuli for the gastric acid secretion. They are vagus, which releases acetylcholine, the neurotransmitter. So that's called as a neurocrine effect. Gastrin, which is a hormone, so it's an endocrine effect. And histamine, which is a neighboring cell, ECL cell, that's a paracrine effect. A parietal cell with its canaliculus has the receptors for these three stimuli. Stimuli for the receptors for these three stimuli: gastrin and its receptor, histamine acting via H2 receptor, and vagus releasing acetylcholine, and acetylcholine acting via M3 muscarinic receptor of the acetylcholine. Histamine not only directly stimulates the parietal cell for HCl secretion, but it has a potentiating effect on the other two stimuli, that is on the acetylcholine and gastrin. That's the potentiating effect. Second cell in the stomach wall is G cell in the pylorus. G cell in the pylorus synthesizes gastrin. And what are the functions of gastrin? Gastrin increases the gastric acid secretion, and it increases the gastric motility. As we have already seen that gastrin increases the motility of the stomach and therefore hastens the gastric emptying. These are the cells in the stomach. Well, there is one more cell which needs to be discussed, but before that, let me ask you a question, a quick MCQ. There was a question: which of the following is a pro-insulin as well as anti-insulin? And the options given are somatomedin, somatostatin, glucagon, and pancreatic polypeptide. Now, the answer was somatostatin. So let's discuss some aspects of somatostatin. Somatostatin is synthesized by the following cells: a D cell in the pylorus and first part of the duodenum, then delta cell in the pancreas, and hypothalamic neurons. So somatostatin synthesized and secreted from various places in the body. When it comes from the D cell in the stomach, what is its function? Its function is to decrease the gastric acid secretion. When pyloric pH falls below 2, somatostatin will come into action and it will decrease the further gastric acid secretion. Somatostatin is also released by delta cell of the pancreas. You see, alpha cell secretes glucagon, beta cell insulin, and delta cell. And then there is a PP cell which secretes pancreatic polypeptide. So we are talking about the insulin delta cell, I beg your pardon, the delta cell from the pancreas. What is the function? Function is it suppresses the insulin and glucagon secretion. So you see, somatostatin decreases the insulin secretion. In that sense, it is anti-insulin. And the third, somatostatin is also released by, it is synthesized by hypothalamic neurons. This is where it is called as GHIH, growth hormone inhibiting hormone. So it goes to the pituitary, anterior pituitary, and it inhibits the growth hormone secretion. In that sense, see, growth hormone is anti-insulin, and therefore the hormone that suppresses it would be a pro-insulin. Therefore, somatostatin in that sense is, by decreasing the insulin secretion, is anti-insulin, and by inhibiting the growth hormone, it is pro-insulin. That was the MCQ on somatostatin. These were the cells in the stomach. Let us see the cells in the duodenum, or rather cells in the small intestine, let's call it that way. S cell in the duodenum, it secretes secretin. An interesting fact, do you know which was the first hormone to be discovered as a hormone? It was named as hormone and its properties as a hormone were discovered. The answer is secretin. Now this secretin released from the S cell, and the only function of secretin is to maintain the alkaline pH in the small intestine, to maintain the alkaline pH in the duodenum. So secretin is secreted in response to acidic chyme entering the duodenum, and then what it does, two main actions. It constricts the pyloric sphincter, so further acidity will not come into the duodenum, and it causes secretion of bicarbonate rich pancreatic juice. The bicarbonate rich pancreatic juice will be secreted in response to the acidic chyme entering the duodenum, so that the acidity can be neutralized by this bicarbonate, the alkali. Then next, I cell in the duodenum. I cell in the duodenum secretes CCK, cholecystokinin. Now this cholecystokinin has multiple actions. Let us see. Cholecystokinin is first, it's secreted in response to fat breakdown products reaching the duodenum, and then it has these actions. First, it decreases the gastric motility, so that further gastric emptying will be prevented. Second, it increases the intestinal motility. That's another action of CCK. Now next two actions are important. It causes enzyme rich pancreatic juice to be secreted from the pancreas. Enzyme rich pancreatic juice is secreted under the influence of CCK. So CCK, its main role is in the digestion of the nutrients, and therefore enzyme rich pancreatic juice will be secreted in response to CCK. And the fourth is, CCK is an important component in fat digestion and absorption. So CCK will cause bile flow from the gallbladder. Bile flow from the gallbladder. Therefore CCK is called as a cholagogue. It's the strongest cholagogue. What's a cholagogue? Cholagogue is the substance which causes gallbladder contractions and causes bile flow from the gallbladder. The other type of substances, of course, are choleretics. Choleretics which increase the bile flow from the liver, bile secretion from the liver. So increasing the bile secretion from the liver, those substances are called as choleretics. Therefore, just to mention it here, bile acids are choleretics. Bile acids, they increase the osmic flow of bile from the hepatocytes, so they are choleretics. Vagus is also another choleretic. It increases the bile secretion from the liver, from the hepatocytes. Well, we are talking about the regulatory peptides related to the digestive tract. We have seen some of the important ones. We have also seen motilin. The MO cell secretes motilin, and its main action is to increase the MMC contractions, strengthen the MMC contractions. Let's see some other names, some slightly fancy names among the regulatory peptides. For instance, bombacin. Bombesin is also called as GRP, gastrin releasing peptide. The bombesin is gastrin releasing peptide. This is a neuropeptide. Let's just show it with a diagram here. This is a G cell in the pylorus. Now this G cell is going to secrete gastrin. It has got the innervation of vagus. Vagus innervates the G cells. And these vagal nerve endings on the G cell, what is their neurotransmitter? Is that acetylcholine? No. These nerve fibers, they release bombesin or GRP as the neurotransmitter, or rather neuropeptide on the G cells. And then there will be secretion of gastrin from the G cells. So that's one neuropeptide. Another regulatory peptide is peptide YY. Peptide YY has been recently discovered. It's not so much known about it. First of all, what is this Y? We already know one neuropeptide Y. It's secreted elsewhere with a certain function. But what's Y? Well, first thing, Y is, in this case, it's a single letter code for the amino acid tyrosine. We know that amino acids, each one of them has been given a single letter code. So tyrosine is having the code of Y. And therefore this peptide is called as peptide YY because it has got two adjacent tyrosine residues. That's a peptide YY. It's also called as peptide tyrosine. Now, this is released by the ileal mucosa in response to fat reaching the ileum. Mainly it is from the ileal mucosa in response to fat reaching the ileum, and it prevents the further gastric emptying so that the fats are not rapidly entering the duodenum, jejunum and ileum, and they are not excreted into the stools as steatorrhea. So this is a peptide which in a way prevents steatorrhea. It also in some unknown way regulates the hunger and appetite and overall energy balance. Even in that it is involved. Then next, incretins. What are incretins released by the GI mucosa? Now we know that oral glucose causes more insulin secretion compared to intravenous glucose, IV glucose. Why? Because oral glucose has a double effect. A, it directly causes insulin release from the pancreas, and B, there is an incremental effect which is what being called as incretins. What are incretins or incretin effect? Is that oral glucose, when it enters the small intestine, the GI mucosa will release certain factors in response to oral glucose, and these factors will go to the pancreas and will cause an additional insulin secretion, incremental insulin secretion. So that's what is where we are referring to incretins, the factors released by GI mucosa in response to oral glucose, and then they will go to the pancreas and increase the insulin secretion. Two well-known candidates are, one is GLP, glucagon-like peptide, and GIP. Now this GIP is, when it was discovered, it was called as gastric inhibitory peptide because it was found to inhibit the gastric motility and gastric secretion. But later on it was found that this function of GIP is not in the physiological doses but in the pharmacological doses, and then GIP, its role as incretin was found out later, and then it was renamed as the GIP, its full form was renamed as a glucose dependent insulinotropic peptide. glucose dependent insulinotropic peptide. So it will cause insulin release in response to oral glucose. That's GIP. From a gastric inhibitory peptide to glucose dependent insulinotropic peptide. These are the regulatory peptides and their functions in the digestive tract. Now let's finally see the secretions in the digestive tract, and then we'll see some aspects of digestion and absorption. So let us start with the salivary secretion. Before we discuss these secretions, let me ask you two quick MCQs which are connected with these secretions. First, potassium concentration is highest in which of the following digestive secretion? Potassium concentration is highest in which secretion? And the options are saliva, pancreatic juice, bile, and colonic secretion. Well, second MCQ, potassium secretion is highest by volume in which of the following secretions? And take same four options: saliva, pancreatic juice, bile, or colonic secretion. Well, by volume, highest potassium content is in the saliva per day, and maximum potassium concentration is found in the colonic secretion, because colon secretes potassium, but it absorbs water and potassium gets concentrated in a very high concentration. So therefore highest concentration would be in the colon, but highest volume will be in the salivary secretion. Let us start with an MCQ before we actually discuss the salivary secretion. Well, just an important fact: all the digestive secretions are under dual control, endocrine control and neurocrine control, except saliva. Saliva does not have any endocrine control, it has exclusively neural control, neural regulation. Well, there was an MCQ: under the conditions of sialorrhea, which of the following will be found to be low in the saliva under the conditions of sialorrhea? And the options are sodium, potassium, chloride, and water. Which of the following will be low in the saliva? The answer is potassium. Let us try to understand that and then also see the other contents of the saliva. Here is a salivary secretion, a salivary acinus end piece. Primary salivary secretion is isotonic. It comes from the blood, and its primary salivary secretion would be rich in sodium, chloride, and water. It is isotonic. But then, as it starts flowing through the duct, there is ductular modification. Ductular modification. That is, sodium is reabsorbed and potassium is secreted. Chloride is reabsorbed and bicarbonate is secreted. And the duct is impermeable to water. So please note this first point, that the duct is impermeable to water. Therefore, whether there is a high flow rate of the salivary secretion or low flow rate, whether it is primary or final salivary secretion, it will be always high in water. That's one thing. Duct does not remove water. Now you can see final salivary secretion will be rich in potassium and bicarbonate, which are added, and sodium and chloride have been removed. Well then, when there are high flow rates of the salivary secretion, sialorrhea for instance, then there will be no time for ductular modification, and in that case the final salivary secretion will resemble the primary secretion. When there are high flow rates, then primary salivary secretion will flow very rapidly through the duct. There will be no time for ductular modification, and therefore final salivary secretion will resemble the primary secretion only. So then in that case it will be rich in sodium chloride and water and low on potassium and bicarbonate, which could not be added. There could not be ductular modification if there is a high flow rate of the salivary secretion. Let us see some aspects of saliva. Its pH is in the range of 6 to 6.5. Final salivary secretion is hypotonic, as can be clearly seen that sodium has been removed by the duct, but water has stayed back, and that means the final secretion will be hypotonic. Two ions, important ions in the saliva, are potassium and bicarbonate. Highest potassium content will be in the salivary secretion. Two important enzymes in the saliva. Ptyalin, which is an alpha amylase. So carbohydrate digestion starts with the salivary action, and lingual lipases. Lingual lipase for the digestion of lipids. So effectively there is no enzyme for the digestion of proteins there. Now the other things in the saliva are thiocyanate ions. Then for the defense mechanism there are IgA antibodies, secretory antibodies. There is lysozyme. Some blood groups antigens are secreted into the saliva by some people. So therefore these are the contents of the saliva and secretion of the saliva. As you know, the functions mainly in the digestion of carbohydrates, starting of the carbohydrate digestion, which stops in the stomach. By the way, amylase cannot act in the acidic pH, so it will stop in the stomach. But lingual lipase does not have a pH barrier. It will continue to act in the stomach and first part of duodenum as well. Therefore, that's the function of saliva, mainly the digestion. Then it helps in the speech, it helps in the formation of bolus of food, and so on and so forth. Let us see the gastric secretion. Stomach. Let's see the cells of the stomach and the secretion. There are gastric cells, and rather gastric glands and pyloric glands. Gastric glands and the pyloric glands. The pyloric glands have G cells which secrete gastrin. So we already have done that part. Gastric glands are they have three cells. Mucous neck cells which secrete mucus. When do you write MUCUS and when do you write MUCOUS? Very often people are not aware of this. When you say the secretion, it's MUCUS. When you are talking of a cell or a gland, it should be MUCOUS. Second cell is peptic or chief cells. Peptic or chief cell. It secretes pepsinogen, which then forms the pepsin. That reminds me of one MCQ which was asked related to these enzymes. Which of the following enzymes is not synthesized in the inactive precursor form? And the options were pepsin, chymotrypsin, carboxypeptidase and phospholipase. The answer is phospholipase. All the others are synthesized in inactive precursor forms. As you can see, pepsinogen is synthesized first and then pepsin is formed. Or chymotrypsinogen forms the chymotrypsin, or procarboxypeptidase forms the carboxypeptidase. Only phospholipase is the enzyme which is not synthesized in the inactive precursor form. Alright, the third type of cell is a parietal cell. The oxyntic glands, or sometimes called oxyntic cell or parietal cell, it secretes HCl and intrinsic factor of Castle. As we are aware, intrinsic factor of Castle will bind the vitamin B12 in the food, and it will go all the way to the ileum from where B12 will be absorbed. These are the cells. Apart from this, what are the other things and their functions? Let's see their functions one by one, and then the phases of gastric acid secretion. Pepsin, protein digestion. About 10 to 20% of the protein digestion occurs by the action of pepsin in the stomach. Second point, it is needed for the further gastric acid secretion or gastric juice secretion. Pepsin action will cause the protein breakdown products, and those protein breakdown products are necessary for the further gastric juice secretion. And the third thing is digestion of meat protein, meat collagen. There are so many proteolytic enzymes in the digestive juice, in the digestive tract, but it's only the pepsin that can digest the meat collagen. Apart from this, what are the other contents? We have already discussed intrinsic factor of Castle needed for absorption of the B12. HCl, it's needed to maintain the acidic pH primarily, apart from the other functions of HCl, but it's needed for maintaining the acidic pH, because pepsin action is going to occur in the acidic pH. That's the function of HCl. What are the other things like renin? This is renin, renin, enzyme secreted in the stomach. This is for the digestion of milk protein. Renin, this enzyme is important mostly in the children, and it digests the milk protein. Casein, it's acted upon by the renin, so curdling of the milk or action on the milk protein. Then gastric lipase, that's another enzyme in the gastric juice. Gastric lipase is a tributyrase, and it digests the tributyric acid or butter fat. It is acted upon by the gastric lipase. Let us see the phases of the gastric acid secretion. Phases of the gastric acid secretion. Now, before I tell you this, let me ask you an interesting question. Normally, as an appetizer, we have tomato soup or cream of tomato, and you will always find that there are breadcrumbs in it. What's the function of those breadcrumbs in the tomato soup, cream of tomato? Are they there for garnishing, or do they serve any function, or what? Well, this is to be seen as an appetizer. You see, gastric phase of the gastric secretion we are looking at when we talk of the appetizer like a tomato soup. If you only give tomato soup, it's a liquid and it will pass through the lesser curvature. It will not distend the stomach wall. And gastric phase of the gastric acid secretion, as we will see just now, it needs some distension of the stomach wall. So you need some solids. That's where the breadcrumbs come in. But that solid should not fill the stomach, and it should not remain in the stomach, lest it will give this a sense of satiety. So we need such a content that there is a distension of the stomach wall, the gastric acid secretion has been stimulated, and then it mops up everything, the acid and the tomato soup and everything, and it will disintegrate and it will move forward. Breadcrumbs will disintegrate rapidly and move forward, so that everything has been mopped up and the hunger has been initiated. Appetizer, it was taken as an appetizer. So and yet the stomach will be mostly empty. That's why the breadcrumbs in the tomato soup. That's how we can remember. However, let's see the phases of the gastric acid secretion. 1. Cephalic phase. 20% of the total secretion occurs in the cephalic phase. It is mediated by vagus. So it will be prevented by vagotomy. Vagotomy will prevent it. What is the cephalic phase of the gastric acid secretion? Sight of the food, smell of the food, thought of the food. That means food in the head. Cephalos is head. Food in just head. You are thinking about the food and there is gastric acid secretion. That's the cephalic phase. Second, gastric phase of the gastric acid secretion. 70% of the total secretion occurs in the gastric phase. So when food is eaten actually and it goes into the stomach, there will be gastric acid secretion. This is mediated partly mechanically, as I described earlier, and partly chemically. Mechanically is by distension of the stomach wall as we eat the food, and chemically is by the protein breakdown products. Protein breakdown products. They will further initiate the gastric acid secretion. So that's the gastric phase of the gastric acid secretion. It's mediated by gastrin hormone. Stimulated by the gastrin hormone. Third, intestinal phase of the gastric acid secretion. About 10% secretion occurs in the intestinal phase, means food has gone from ahead, from the stomach into the intestine, and still there is a gastric acid secretion. This is mediated partly by the gastrin, and it will be inhibited by certain factors like enteroxytocin or neurotensin. So these are the phases of gastric acid secretion. Let us see the pancreatic secretion, but before that let me just have a correlation. Even pancreatic juice secretion has these three phases: cephalic phase, gastric phase, intestinal phase, depending on where the food is there. So cephalic phase, 10% pancreatic juice secretion. Gastric phase, 10 to 20% secretion of the pancreatic juice, and main 70%, that's maximum, is in the intestinal phase. Obviously when the food reaches intestine, that's where the pancreatic juice is needed. Pancreatic juice. Let us see some important aspects of the pancreatic juice. Its pH is the highest among any juices. It will be 8 or more. So among all the digestive juices, lowest pH will be that of gastric juice and highest pH will that be of pancreatic juice. Now it is isotonic. Pancreatic secretion is isotonic. Saliva was hypotonic. Pancreatic juice comes in two types. One is bicarbonate rich and the other one is enzyme rich. So when acidic chyme enters the duodenum, that time bicarbonate rich will be secreted from the pancreas under the influence of secretin hormone, and enzyme rich secretion will occur when fat breakdown products or generally the nutrients enter the duodenum. that will be under the influence of CCK hormone. Now, let us see some of the enzymes in the pancreatic juice and their functions. But before that, let me tell you an interesting fact. Which organ in the body has highest protein content by weight? The maximum protein content is in which organ of the body? This is liver or skin or brain or pancreas? The answer is pancreas. All the enzymes in the pancreatic juice, there are so many of them, they are all proteins, and plus the pancreatic architecture. All in all, highest protein content by weight is seen in the organ, that's the pancreas. Highest in the body is for pancreas. Let us see some of the enzymes. Now, all the enzymes in the pancreatic juice, barring phospholipase, all of them are in inactive precursor form. So first enzyme to be activated is trypsin. Trypsinogen is secreted by the pancreas. When it comes into the duodenum, there is another enzyme secreted by the duodenum, that's enterokinase enzyme. It converts trypsinogen to trypsin. So first enzyme to be activated is trypsin from trypsinogen, and then there is autocatalytic conversion, that trypsin will form more and more trypsin from the trypsinogen. So it's called as autocatalytic conversion. And there is also trypsin inhibitor which will finally stop the trypsin formation. And then trypsin will act on chymotrypsinogen to convert it into chymotrypsin. So these are the important peptidases in the pancreatic juice. Aminopeptidase, carboxypeptidase, these are also the peptidases. They are required for protein digestion, but these are the most important ones. What's the difference? Let me just tell you the difference between trypsin, chymotrypsin and carboxypeptidase, aminopeptidase. Trypsin, chymotrypsin are called as endopeptidases. Endopeptidases. They break some interior bond of a protein. So they will make two big pieces of the protein during the digestion. Whereas carboxypeptidase and aminopeptidase, these are called as exopeptidases. Exopeptidases are the ones which break the external bond of the protein. So these are the peptidases. Apart from the trypsin, chymotrypsin, the pancreas has the other enzymes like lipase, colipase, and phospholipase A and phospholipase B. What is the function of colipase? Lipase enzyme is likely to be inactivated by the bile salt molecules, and that is prevented by colipase. Apart from that, carbohydrate digestion, amylase. Of course, this amylase is similar to the salivary amylase, but 40 times more potent as compared to the salivary amylase. In the other enzymes, nuclease and ribonuclease and such enzymes. So practically digestion of all the nutrients present in the pancreatic juice. And then the succus entericus, secretion of the intestine, called as succus entericus. The succus entericus has mainly, it has got disaccharidases like sucrase, maltase and lactase. So disaccharides will be broken down into the monosaccharide stage for the sake of absorption. That's succus entericus, the intestinal juice secretion. it will also contain di and tripeptidases, so aminopeptidase, for example, would be in this. It has got the enzyme called trihalase. So for sugar molecules, for their breakdown, the special enzyme present there. Now these are the enzymes in the succus entericus. We have seen some of the secretions in the digestive tract. Let me just tell you quickly about the bile. Bile. You see, there is hepatic bile and there is gallbladder bile. So what are so bile is synthesized by the liver. It has bile salts and bile pigments. Bilirubin, biliverdin are the bile pigments, and then the bile salts. And then it comes to the gallbladder. This hepatic bile will come to the gallbladder. Gallbladder has only about 50 ml or so capacity, so not much. What are then the functions of the gallbladder? What does it do to the hepatic bile? Gallbladder stores the bile. It concentrates the bile. Gallbladder epithelium removes water from the bile, and the bile is concentrated. It acidifies the bile, and it also adds mucus to the bile. So these are the important functions or actions of gallbladder on the bile which is coming from the liver. So these are some of the secretions in the digestive tract and what their functions are. Finally, we will see the digestion and absorption. Well, digestion is such that carbohydrate digestion starts with the amylase, salivary amylase. So polysaccharides will be broken down to the oligosaccharide stage. Then pancreatic amylase will further break down those oligosaccharides to convert them into disaccharide stage. And then we saw disaccaridases in the succus entericus. They will break it down further so that the monosaccharides will be formed and they will be absorbed. Similarly, lipid digestion. Short chain fatty acids can be, their digestion can begin as they are water soluble, so watery enzymes like lingual lipase can act on it and digestion can start. But long chain fatty acids, their digestion needs the action of bile salts. So let me tell you the functions of bile salts in the digestion. One function is in the digestion of lipids. Digestion of lipids. This is emulsification action. Emulsification action of the bile salts. You know, bile salts, they have a detergent action on the lipids. Lipids are immiscible in water, whereas our entire milieu in the intestines is watery. It's filled with watery enzymes. So therefore, bile salts will have that detergent action. They will have a chopping action so that lipids will be broken down and their surface area will be increased tremendously. After that, the enzymes lipase, colipase, they can act on it. Second function of bile salts is in the absorption of the lipids. Absorption of the lipids. Now, bile salt molecules, about 20 to 40 bile salt molecules, they come together to form a micelle. A micelle made up of 20 to 40 bile salt molecules. Their hydrophobic tails are pointed inward, where there is fat digestate. Fat digestion products are accumulated inside, within, in the micelle, and water soluble parts are on the outside. So in this manner, the function of micelle is in the fat absorption. That is, it will remove the fat digestion products from the site of fat digestion and then it will be taken to the jejunum, from where it will be absorbed. Those fat digestion products will be absorbed. That's the function of micelle. This is called as ferrying function of the micelle. It is causing a ferry boat function, that fat digestion products will be removed from the digestion site. It will be taken to the jejunum absorption site. Then the micelle will go back and will take more fat digestion products. That's a ferrying function of micelle. That's an important function of the bile salts in the digestion and absorption of lipids. And digestion of proteins, as we have seen, it starts with the action of pepsin. The polypeptides will be broken down to oligopeptides. Then further action by trypsin and chymotrypsin. So it will be brought down to the stage of di and tripeptide, and then finally di and tripeptidases in the succus entericus will cause the further breakdown, and then the amino acids will be absorbed into the blood. Let us see the absorption of nutrients from various parts. Stomach. Does it absorb anything? Well, stomach absorbs alcohol. You know, it can be remembered easily. Alcohol is the only thing absorbed from the stomach, and morphine is secreted into the stomach. You know, in the IV morphine poisoning, even if it's an intravenous poisoning of morphine, they give gastric lavage because morphine is secreted into the stomach. Well, but we are concerned with absorption of nutrients. Alcohol is absorbed from the stomach. Next, duodenum. What all things are absorbed from the duodenum? Most of the divalent cations are absorbed from the duodenum. So, iron, calcium, except magnesium, because magnesium is absorbed from the ileum. Otherwise, divalent cations are absorbed from the duodenum. Jejunum. What's absorbed from the jejunum? All the major nutrients are absorbed from the jejunum. So, even water, as we have said, maximum water absorption absorbed from the jejunum. Already discussed this point. 6.6 liters of water absorbed per day from the jejunum, and 1.5 liters absorbed from the colon. That's about the water absorption. A total of 8.8 liters of water are absorbed per day. Out of this, these two are the major sites. Jejunum 6.6 liters, colon 1.5 liters. Remaining from the other places. One more point to be remembered is all the nutrients which are absorbed from the jejunum, they are absorbed into the portal blood. Obviously, they are absorbed in the portal circulation and they are taken to the liver. That's a very obvious thing to know. Except the long chain fatty acids. These, when they are digested, they are absorbed into the lymphatics of the intestine. They are absorbed into the lymphatics. Because of the absorption of long chain fatty acid into the lymphatics, they appear milky, and for which they are called as lacteals. So, they are absorbed into the lymphatics in the form of chylomicrons. And finally, those chylomicrons will be drained via lymphatics at the junction of the two major veins. That's how they will go into the blood. But remember, all the nutrients absorbed into the portal blood and they go to the liver directly, except the long chain fatty acids. So that was about the absorption from the jejunum. Finally, ileum. What all things are absorbed from the ileum? As we have discussed, magnesium ions absorbed from the ileum. Vitamin B12 absorbed from the ileum. Bile salts absorbed from the ileum. I wouldn't say absorbed. There is enterohepatic cycling of bile. So bile which has come from the gallbladder or from the liver into the duodenum, it is involved in fat digestion and absorption. Then it goes to the ileum, from where it will be absorbed. It goes back to the liver. That's called as enterohepatic cycling of bile. There was a question like this: enterohepatic cycling of bile occurs how many times a day? 1 to 2, 3 to 4, 5 to 6, 7 to 8. The answer is 7 to 8 times a day. Enterohepatic cycling of bile occurs because it is assumed that we eat 3 to 4 times a day, and each time we eat something, the bile will come into the intestine and will be absorbed. So it will move twice over, and therefore totally 7 to 8 times a day enterohepatic cycling of bile occurs. Well, so bile salts are absorbed from the ileum in that sense for enterohepatic cycling. Maternal antibodies in the newborn are absorbed from the ileum. You know, in the newborn baby, if it has there are maternal antibodies through the milk, for instance, they are absorbed from the ileum. So these are some of the things absorbed from the ileum. A final MCQ on the digestive tract coming up. I will mention 4 substances. Which of them are synthesized by the gut microflora and also absorbed from the colon? The options are, I'm mentioning 5 substances. 4 of them are synthesized by the gut microflora, or rather I would say colonic microflora. Microflora of the colon synthesizes and absorbs these substances. Well, instead of MCQ, let me just mention all those substances. Colonic microflora will synthesize these substances and they are also absorbed then after that. They are vitamin B12, folic acid, vitamin K, and short chain fatty acids. These are the substances which are synthesized by the colonic microflora and they are also absorbed from the colon. So, for example, short chain fatty acids, you know, our undigested carbohydrates, when they reach the colon, the colonic microflora will retrieve them and in a sense salvage the energy from them, and they will form the short chain fatty acids from the undigested carbohydrates. So these are some of the aspects of digestive tract and digestion and absorption and the related issues.